My name is Madison Wagner, and I'm a clinical solutions specialist at Perspectum. It is my pleasure to introduce my colleague and Perspectum's medical science liaison, Professor Carlos Dunker.
Thank you, Madison. Hello, everyone, and welcome to this presentation. Thank you for taking time out and being here with us. We hope that you find the content of this session interesting. We'd love to hear from you.
Today, we will be covering some of the clinical myths and facts of FibroScan's CAP and KPA metrics, as well as the technology of Perspectum's liver multiscan and its PDFF and CT1 metrics. This video will share the opinions of Professor Dunker and the evidence of utility found within published studies around diagnosis and monitoring of liver disease. Non-alcoholic fatty liver disease, NAFLD, affects millions of people, and it is a diagnostic consideration mainly among patients with elevated LFTs or patients with radiologic findings of hepatic fatty infiltration. The diagnosis of NAFLD requires evidence of fatty infiltration of the liver. Confirmation of hepatic steatosis is usually done by imaging, and among the two most frequently used technologies and clinical pathways are FibroScan's Controlled Attenuation Parameter, or CAP, and liver multiscan's Proton Density Fat Fraction, or PDFF, which is done by magnetic resonance imaging. I have 4 specific bullet points that I'd like to ask you about today, since these are questions or topics that I am often questioned of in the clinical setting. The first, that CAP score can distinguish between grades of liver steatosis. The second, that CAP score is successful across BMI ranges. The third, that CAP is highly specific for assessing steatosis. And lastly, that CAP is an accurate measure. Okay, so first, can CAP score distinguish between grades of liver steatosis?
This is a very good question, Madison. The fact is that CAP cannot accurately distinguish between grades of steatosis. There are plenty of publications addressing this issue. The fact is that FibroScan CAP cannot accurately distinguish between steatosis grades. Strong discordance has been reported between histology and CAP. This discordance worsens as hepatic steatosis increases, to the point that FibroScan cannot distinguish between grades of steatosis with either the M probe or the XL probe. Furthermore, CAP is affected by other factors beyond body mass index, including NAFLD, NASH, type 2 diabetes, age, sex, and operator experience. On this next slide, on the graph to the left, we can see that FibroScan's CAP can be useful to differentiate between patients with no liver steatosis from those with liver steatosis. However, to answer your question regarding grades of steatosis, let's look at the pink table on the right, showing OROC values in an obese population. We can see that the accuracy of the CAP value is severely impaired in this population, and it fails to distinguish between the different grades of hepatic steatosis, with an accuracy of only 0.64 for those with steatosis grade 2, and even lower at only 0.58 for those with steatosis grade 3. FibroScan's ability to differentiate between different grades of liver steatosis grade 1 is severely impaired by patient populations with high BMIs. These results show that FibroScan CAP cannot be used to stratify by grades of liver steatosis. It cannot be used to quantify liver steatosis, nor to monitor liver steatosis over time or as a response to a therapeutical intervention, which may be the most important factors to assess in the follow-up of patients with NAFLD and NAFLD NASH.
Let's review myth 2, that CAP score is successful across body mass index ranges.
Well, this question is related to the previous one. The fact is that FibroScan's CAP measures are severely confounded by fat. The more fat, the less accurate, which in NASH patients is a problem if you consider that reliable, accurate results are in order. The second pink bar, the one on the right, shows that success rates of FibroScan are relatively poor. FibroScan fails in about 22% of patients. And importantly, the success rate of CAP may be even lower as BMI increases. An important advantage of MRI using PDFF to measure liver fat is that the success rate of this technology is consistent across BMIs, and success rates average 95%, as shown in the first bar of this graph. BMIs greater than 30 have been shown to be the main cause of CAP measurement failure, but on top of this, other reasons for CAP failure have been described to be female gender and metabolic syndrome.
Myth 3. That CAP is highly specific for assessing steatosis.
Well, Madison, this is common belief. However, the fact is that MRI-PDFF has superior specificity than CAP for assessing hepatic steatosis. Just as we saw on one previous slide at the beginning of this presentation, here again on the second graph, we can see that correlation of CAP versus steatosis grade is only 0.4. In the graph on the left, we can see that the correlation of PDFF is much better at 0.7. On the last column of the table on the right of this slide, we can see that specificity of PDFF for the 3 grades of liver steatosis is 100%, while that of CAP is only between 41 and 60%. This again puts PDFF, as measured by liver multiscan, at an advantage of significant clinical interest when assessing hepatic steatosis in patients with NAFLD.
And lastly, myth 4. That CAP measurements are accurate.
This is actually also a very interesting observation. The fact is, in reality, that diagnostic accuracy of MRI-PDFF is far superior to that of CAP, as it has been shown in multiple cohorts. In this slide, we can see the results of 3 different published papers that, interestingly, used liver biopsy as reference. 2 of these papers are from the US and 1 from Japan. All 3 publications very similarly show that across all grades of hepatic steatosis, the area under the curve for MRI-based PDFF, the yellow bars, is better than the area under the curve for FibroScan's CAP value, the blue bars, which once more demonstrates that MRI-based PDFF has better accuracy for distinguishing patients with liver fat across all grades of steatosis on liver biopsy. On this other slide, we can see this prospective study of 185 subjects with suspected NAFLD. All subjects were recruited from a single center in San Antonio, Texas, and results were also compared to liver biopsy. Focusing only on the graph on the far right in yellow, we can see once again how the area under the curve is better for PDFF than that for CAP for the assessment of liver steatosis equal or greater than steatosis grade 2 on liver biopsy. Finally, on this next slide, we can see a cross-sectional prospective study from Yokohama City University in Japan. 97 patients undergoing liver biopsy were screened with MRI-PDFF, MR elastography, and FibroScan. On the first graph on the left of this slide, we can see on the second bar, from left to right, that PDFF was successfully obtained in 100 of the subjects. FibroScan was not able to provide a measurement in 7.2% of patients. It provided unreliable measurements on 10.3% of patients and provided a failed measure in 4.1% of the patients. In summary, FibroScan failed on 22% of all these patients. The graph on the right shows that the area under the curve for PDFF in pink is significantly better than that for FibroScan's CAP value in blue, both for the detection of subjects with a NASH of 4 or more and for the detection of subjects with steatosis grade 2 or more. In summary, unlike FibroScan's CAP value, PDFF, as the best-in-class PDFF and one of the 3 metrics provided by Perspectum's liver multiscan, excels in measuring hepatic steatosis across entire slices of the liver, and it is unaffected by high BMIs, which are common in NASH populations. In addition to this, PDFF has a low variability between measurements, enabling serial assessment to reliably monitor changes in liver fat content as a result of therapeutic interventions, which is of special interest in the clinic as it is in research.
Professor Dunker, thank you for your time and clarification of these most common myths and misconceptions. You've made it clear that CAP cannot accurately distinguish between grades of steatosis, that CAP measures are severely confounded by fat, that MRI-PDFF has superior specificity than CAP for assessing hepatic steatosis, and that diagnostic accuracy of MRI-PDFF is far superior to that of CAP. Thank you. Please find here all references used to come to our conclusions today. I hope you found this informative, and please, if you have any questions or wanted to talk further, our contact information is below.